Good afternoon. My name is Dr. Katie Wells, and I am the Director of Social Medicine at the Larner College of Medicine. It's my privilege to welcome you to our Healthcare Series Grand Round session today. The Health Cultural Awareness, Research, and Education, our C.A.R.E Grand Round Series, is a CMIE accredited education series sponsored by the Office of Inclusive Excellence. It's designed for faculty, staff, residents, and students who are interested in exploring a variety of health-related concerns that impact diverse groups. This series also provides an opportunity to delve into the history and current state of medicine. The primary goals of this series are to empower communities, promote cultural awareness and cultural humility, as well as skills among healthcare professionals, and address barriers to healthcare access and quality. The healthcare series includes signature events such as the Reverend Dr. Martin Luther King Jr. Health Equity Lecture, the Ambasciani DeSalvo LGBTQ Health Equity Lecture, and the Gender Equity Education Series, as well as other sessions taught throughout the year that address topics related to inclusive excellence in medicine. Today, we are very honored to host Dr. Amanda P. Williams in recognition of Black Maternal Health Week. Held annually from April 11th to the 17th, Black Maternal Health Week is a week-long campaign founded and led by the Black Mamas Matter Alliance to build awareness, activism, and community building to amplify the voices, perspectives, and lived experiences surrounding Black maternal health experiences. The 2025 Black Maternal Health Week theme, Healing Legacies, Strengthening Black Maternal Health Through Collective Action and Advocacy, emphasizes the power of Black-led perinatal, maternal, and reproductive health organizations to drive systemic change and foster community healing. Before we get started, there are a few housekeeping items I need to go over with all of you. A live captioning link is available in the chat. This lecture is also CMIE accredited, so you can scan the QR codes in the presentation for the evaluation and the link to create credit. These links will be added to the online chat as well. Lastly, there are no financial relationships from speakers or reviewers that need to be disclosed to the audience. I now have the honor of introducing our speaker today, Dr. Amanda P. Williams. Dr. Amanda Williams is the Interim Chief Medical Officer at March of Dimes. She leads March of Dimes' mission team to advance efforts in research, advocacy, education, and programs that will prioritize the well-being of moms and babies. Dr. Williams brings more than 20 years of clinical experience to the role, and her commitment to health equity inspires all to improve maternal and infant health outcomes. Additionally, she serves as the Clinical Innovation Advisor with the California Maternal Quality Care Collaborative, based at Stanford University School of Medicine, where she is also an adjunct faculty member in the Department of Obstetrics and Gynecology. Dr. Williams previously served as the medical director at Mommy Tech-Enabled Maternal Health Company. In this role, she oversaw the company's clinical program while fostering institutional partnerships, developing new business opportunities, and supporting investor outreach. Prior to joining Mommy, Dr. Williams was a practicing OBGYN at Kaiser Permanente in Oakland Medical Center, where she served as Director of Maternal Services. Additionally, she oversaw the maternity continuum across Kaiser's 15 medical centers in Northern California. She has also served on several state and national committees, such as the California Pregnancy Associated Mortality Review, the California Surgeon General's Perinatal Redesign Stakeholder Group, and the National Quality Forum Maternal Morbidity and Mortality Work Group. Dr. Williams is a magna cum laude graduate of Harvard University, where she majored in American medical history and biochemistry. She completed her medical degree at Emory University School of Medicine, where she also received a master's degree in public health, focusing on health policy and management. She completed her graduate medical training in obstetrics and gynecology at the University of California, San Francisco. Dr. Williams is a prominent voice on maternal health and health equity. Her expertise has been showcased at prestigious institutions like Rush, Harvard, Stanford, Georgetown, and Howard universities. A sought-after speaker, she has now been featured at the Future of Maternal Healthcare Summit, the Fortune 500 Most Powerful Women Next Generation Conference, the Doula Expo, and MenoFest. Finally, she has been interviewed on national television outlets such as PBS, BET, CNN, and MSNBC, and in print media such as the New York Times and the Washington Post. We are so privileged to have Dr. Williams here today. Please join me in welcoming Dr. Williams.
Thank you so much, Dr. Wells. When I listen to all that, I'm like, oh God, I'm old, but I've done some good stuff, which has and it is a privilege to be able to be here with you guys. Happy Black Maternal Health Week. We are here to learn and to celebrate as well. So let me make sure that I am sharing my slides appropriately. All right, can someone give me a thumbs up and let me know that they see my slides okay? All right, fantastic. So, what we're going to be talking about today is building a perinatal infrastructure to promote health equity. So, what the heck does that mean? So, what I'm trying to get to is that health equity is not about a checky box on a training. There actually has to be intentional design inside of an organization or a system or a department in order to not just pass some kind of evaluation that everybody learned about implicit bias, that you're actually trying to change an organization. So that is what we're going to try to focus on today. I do have some disclosures. I have the privilege of working in a lot of different spaces and really being able to bring all of these different vantage points to the maternal health ecosystem. So I do still advise a couple of different maternal health startups, Bloom Life and Risk LD. I was internal at a maternal health startup for about 18 months after I left the behemoth at Kaiser that insures 4.5 million women in Northern California. And then my research has been funded over this last year by the Longs Foundation, Merck for Mothers, March of Dimes, where I now work, and CDC and NIH, at least for the moment. We know that we are probably going to lose our funding effective this summer, which is a real pain point for me, but I'm not going to dwell on it. I'm going to stay in the positive and focus on what we can still do. I always start my talks by honoring the fact that there are many people that are in this pregnancy and postpartum experience. You'll hear me say mother, birthing person, she, they, pregnancy capable people. We want to honor the fact that there are many people who go through this birth, and who they choose as their family and how they identify is part of honoring a respectful birth experience. So our objectives today, I probably shouldn't have put 5. That's kind of a lot, but hopefully all of these things will happen. We'll be able to identify 2 maternal health outcomes with disparate outcomes by race, which maybe you guys can do already. Explain data stratification and why that's important in understanding maternal mortality in the United States. Demonstrate the difference between race and racism as a risk factor for poor maternal health outcomes. Give some examples of health equity-centered patient engagement in terms of our solution strategies, and then the benefits of patient story in driving health equity efforts. So, what is the problem that we are trying to solve? So, unless you've been under a rock, and I assume people associated with UVM have not been under a rock, you are aware that there is a maternal health crisis in the United States. We are the worst of our economic peer countries when it comes to maternal mortality. And that on top of being the worst in the country of economic peer countries, there is a racialized component to this, where Black and Indigenous birthing people are dying at rates that are now 3.5 times that of their white peers. And it isn't an accident that we got here. And the painting that you see in the middle is of one of the enslaved women. The ones that have been identified are Lucy, Betsy, and Anarcha by J. Marion Sims, who's known as the father of gynecology. And He did countless unanesthetized, unconsented pelvic procedures on these women. And it truly, truly is horrifying. And yet, that is how gynecology was born in the United States. So, this enmeshed experience of systemic racism and OBGYN is part of this field from the beginning. So it's not a surprise that it takes a lot of work and intention in order to unwind it. And so we're very grateful for the investigative journalism that was going on, particularly 2017, 2018, starting to draw attention to this issue, to celebrities like Serena Williams, who've used her platform to talk about this issue. And then the New York Times headline on the bottom comes from actually one of our studies at Stanford, at CMQCC, where we took all of the maternal deaths in the state of California and matched them with people's tax returns. And what we saw is that even in the highest tax bracket in California, um, Black women are dying at a rate that is twice that of their white peers, and the same for Black babies. So the narrative around not having access, not having appropriate resources, that is an important part of the story, but that is certainly not the heart of it. There's something else that is going on. And I would suggest to you that that something else is the combination of implicit bias and systemic racism. So turning our attention back to the entirety of the United States, this is CDC data looking at our maternal mortality. And when we go from 2018 to 2021, in all of these different demographic groups, we see an upward climb. And we know that part of this upward climb is the COVID pandemic. And it's important to remember that COVID not just made pregnancy outcomes worse. If you are pregnant, your COVID is worse. So they went in both directions when it came to the horrors for pregnant people during COVID. And then we changed our operations in so many ways on our L&D units around the country. And so we were not working in our normal manners and doing our normal proceeding in typical fashion. We had the pandemic, people weren't vaccinated, and pregnant people were very loath to vaccinate, particularly in communities of color. I hope, and having been a senior leader in one of our biggest healthcare organizations in the country at that time and taking care of patients, I pray that I never see a year like that again. It was awful. And everyone was impacted. But what you see here also is the exacerbation of pre-existing racialized disparities. And so we knew that there was something that needed to happen. Fortunately, once more people were vaccinated, once doctors and nurses had a better idea of how to take care of people during the pandemic, we saw improvement. And so when you compare that horrific year of 2021 to 2022, we see improvement across the board. So this is really on the left-hand side of your screen, the result of us understanding and figuring out how to function inside of the pandemic. You'll notice that the disparities do not change at all. So that is in the sort of 2 to 3, just under 3x, the rate of maternal death for Black birthing people compared to their white peers. What you see from 2022 to 2023, which is our most recent data that we have from the CDC, is something very telling about the United States, which is that every group continued to improve except for Black people. So in fact, what that means is that the disparity is worse, right? When you do the ratio and everyone else is improving, but they're not, then the disparity is worse. And that's where we get back to that 3 to 4x number. So This really supports the argument that this is no longer about COVID. This is no longer about vaccination, figuring out how to take care of people. When we go back to pre-pandemic times, what that means is that everyone else has had some benefits, and those downstream consequences of systemic racism are even more notable as other groups continue to improve. I've had my whole career inside of the state of California, and I'm proud of the fact that California has done very well in terms of maternal mortality ratio in the United States. The burgundy line is the United States, the blue is California, and that split that happens between 2006 and 2008 is when CMQCC was born. I'm going to talk about CMQCC a little bit more later, but again, that is the California Maternal Quality Care Collaborative. It is a public-private partnership between the California Department of Public Health and Stanford University, where we bring hospitals together from around the state to address issues of maternal morbidity and mortality and have systematic responses to obstetric emergencies. Moving into more recent times, those two lines never cross again. And we had an entire collaborative around COVID, around sepsis. And our newest collaborative that I have the privilege of being the lead physician on the team is around health equity. Now, just surviving pregnancy should not be the goal, right? That's a really low bar. You should not get a cookie for just your patient survived, and it's something that I used to always have to hammer into residents' minds that yes, this family should be grateful that you saved their life, but if you treated them like dirt, then you are not getting a win. People actually deserve to be treated well, and birth can be an incredibly affirming experience, but we know that brown-bodied people are not treated the same. And people who have public insurance like Medicaid or no insurance, that's another group where people really are being treated poorly. Now, you look at these numbers, like everyone's being treated poorly in pregnancy. This is not good for the field. We need to have more respectful care for our pregnant and postpartum patients, and it's even more so for folks who've been marginalized by our society. All right, I think I've made the case. I hope that you're with me that we have a problem here, that there are issues to solve when it comes to having an equitable experience for birth in the United States, and that there are real differences by race and ethnicity. So when you are going about trying to make this different, yes, it's great to have an implicit bias training, and there's some level setting and language, shared language that can be implemented, but there really is a systematic approach that I would recommend for if you are really trying to make sustainable change inside of a unit or organization. And the first step is alignment. And I feel very grateful to University of Vermont that y'all have given me the ability to speak from all of my perspectives. Someone's like, oh, well, I want to hear about your Kaiser Permanente medical experience, or your startup experience, or March of Dimes, or Stanford, but I'm trying to bring it all to you and sort of take the pieces that I think come together to make a systematic approach to making this different. So when we developed the Health Equity for Women group at the Permanente, so again, Kaiser Permanente, the short way to think about it is Kaiser is the hospitals and health plan, Permanente is the doctors. But we work in an exclusive partnership. So first thing we needed to do is get alignment. So we have to have people speaking the same language. We have to have a mission. We have to have a vision, and words matter. We have to think really deeply about how we're going to frame this. And we wanted to really lean into trust, because we know that some of the issues around equity come from a lack of trust between patients and the clinical teams taking care of them. And so inside of Permanente, what we came up with is we gain trust by providing patient-centered, because we always want the patient at the center, care that honors the unique needs of our diverse patient population. And putting the word diverse in was a battle. We, a very senior leader in our organization was really pushing back. Like, of course it's diverse. Like we're Northern California, like it's a very diverse place. And even though we eat and breathe it, not everyone does. And our patients need to hear that we are thinking about this. Now, in the current climate, that might be a little bit different, but we'll talk about that. We'll talk about that later. Inside of CMQCC, the goal was to really make sure, and this has been since before I was there, to end preventable morbidity, mortality, and racial disparities. So to actually call out the disparities as opposed to just the morbidity and mortality. Because when you are addressing disparities, you're actually going to drive down your preventable morbidity and mortality. Yet there is something to be said about intentional language in getting that alignment. So when we were doing it inside of the Permanente medical group, timing was essential. You've got to make sure you've got the right leaders in place. There's enough of a drive or interest to do the work. So timing is always of the essence. We had one-on-one meetings with key leaders and stakeholders. If your senior folks in your organization aren't bought into it, it's really hard, not impossible. I believe in the power of one, but getting engagement is really important. And in fact, sorry, I'm flipping between organizations, but at CMQCC, when we're running a collaborative, we actually make folks get signatures from senior leaders signing on to supporting that collaborative. And I think those sorts of practices actually do pay off. Data. Always take a look at your data, because we have to figure out, like, where are the key issues. And we have to be able to stratify our data and think about who are the populations that are most affected. We brainstormed with our advisory group. We identified our goals and which projects we were going to work on. Maternal mortality is the holy grail, but it's rare. So even though it's way more in the United States than in other of our economic peer countries, it's still very rare. I've been an OBGYN for over 20 years. I can count on one hand the number of maternal deaths that I've even tangentially been a part of. So we've got to think about other types of projects and goals, not just mortality, but the drivers thereof. And so then we chose our initial projects. So going through that process really does make a difference. So then you've got to build a framework. So there's got to be some sort of container for this work. And I love this graphic from the Robert Wood Johnson Foundation about equality versus equity. So if the look is equality, that I treat everyone the same. And, sometimes still in California in 2025, I have people saying that to me, like, oh, Dr. Williams, we don't need this collaborative at our hospital. We treat everyone the same. And the response is often, I love that is the spirit that's inside of you, is that you treat everyone the same, but the data actually suggests differently. and that our goal is to have equity so that everyone's getting what they need to have the same excellent outcomes. So you can have equality of outcomes, but equity is what gets us to those outcomes. And depending on someone's lived experience, where they're coming from, race, language, insurance type, what is needed, social drivers, like what's needed to make that happen, might be very different. And then we know that we're talking about people coming from all sorts of different places. Why is this clustering inside of particular groups? It's because there can be inherited disadvantage. So it's not that there's something wrong with the DNA of Black people or Indigenous people. It's all of these other pieces of the puzzle, almost all of which are downstream consequences of systemic racism. When we think about segregation and neighborhoods and chronically disinvested communities. When we think about where the toxic pollution is, who are the communities that live in those areas, where are the green spaces for people to live. And then there is the chronic toxic stress that comes from chronically being on guard. And that actually, as we know from the study of epigenetics and methylation, oxidative damage, and stress, that actually affects us biologically. So we have to really think about all the different ways that people's health are being impacted. So now that we're sort of thinking about the health of our pregnant patients more broadly, we have to know that we can't boil the ocean. We can't do everything. So when we're designing a project, what are the pieces that we want? And so when we were putting together this Health Equity for Women group at Kaiser Permanente, we decided that these are the essential elements. We wanted something that we could measure, and reliably measure. And we also wanted something that we had control of in terms of removing barriers. So, as a physician leader inside of a big healthcare system, I can't solve systemic racism. Like, I can't do that all by myself. But what I can do is make it easier for a patient to get low dose aspirin for the prevention of preeclampsia and preterm birth, which disproportionately impact Black patients. So that is a barrier that I can remove. So it's something that's within my domain of control. We wanted something that could empower patients. We want to engender healthy behaviors and empower patients in this space, knowing that it will pay dividends. That because, when a patient gets used to using their voice, when a patient gets used to speaking up, that then they'll do so in other domains as well. And then we want to engage clinicians and staff. We knew that there are downstream benefits in terms of preventing burnout. So, burnout, and certainly around the time of the pandemic, there was lots of it. Burnout is burnout is not solved with bubble bath, right? Burnout is solved by meaning, is solved by self-care in the structural sense. And so we wanted to engage clinicians and staff in this work. So that's how we built our framework. So what I would suggest is that you first have to come up with alignment of your key stakeholders. You have to put your words together. You have to have a framework for the work that you're doing. And then the next step is to use data. And so now I'm coming back to CMQCC and looking at our California. This is because we do our analysis in 2-year chunks to protect people's privacy. This is our most recent data, is this 2019 to 2021. And we see that even though California is super proud of having a very low maternal mortality rate, we have just as bad, if not worse, disparity issues when it comes to Black and Indigenous birthing people in the state. So we should not be sitting on our high horse and saying like, oh, well, California's great. And, we have all these systematic responses to obstetric emergencies. Our patients do really well. Um, a lot of our patients do well, but there are some that don't. And so our work is not done. As I spoke of before, we don't want to just solve maternal mortality. And again, that's very, very difficult, and it's a hard thing to study. But we need clinical outcomes to be able to have a measurement for our interventions, and things like NTSV C-section rate. So that's nullipterm singleton vertex, just first baby over 37 weeks of pregnancy, just one inside and head down. So these are the patients that for the most part should be having a vaginal birth, but too many of them are not. And depending on your racial background, your rate of C-section is quite different. And so this for our perinatal equity collaborative actually has become our clinical outcome that we are following. And it's not Black patients in every center. It might be your Spanish language patients. And in a lot of medical centers in California, it's your Asian patients that have the highest C-section rate. So figuring out what's going on in these different demographics and with the care of patients in different medical centers to be able to have more equitable outcomes. And then severe maternal morbidity, so complications like going to the ICU, take backs to the OR. These also very different depending on racial and ethnic backgrounds. And we see with our API, AIN, Black patients, we see much higher rates of complications. So taking more common outcomes, so severe maternal morbidity in a busy medical center, you will certainly see that once or twice a month. In some really busy places, every week, you may see this type of complication. So we need to not just think about our patients surviving, but we're actually seeing disparate care in more common outcomes, and that can help us understand how did we get to these big disparities in mortality. So it's really important that we stratify our data. And that's one of the places where in this current political climate, we have to be so careful. And we're really, honestly at risk of not being able to design programming appropriately because we're not looking at payer type. We're not looking at geography. We're not looking at race. If we just lump everybody together, then we're actually being irresponsible. Because what you want to do is to target programming for the people who need it most. And part of understanding that is knowing their demographics. So as I said at CMQCC, now we're going to start thinking about designing, right? So we've got the data, we've identified who the at-risk groups are for a particular clinical outcome. And now we want to really design. And CMQCC has done an amazing job in terms of decreasing morbidity and mortality in California, not so great on racial disparities, and we are starting to actually make a dent. So let me just double click on CMQCC to make sure it's clear. We are our state's perinatal quality collaborative. Vermont has one, almost every state has one. Idaho has disbanded, but they're trying to come back together. But the secret sauce of ours in California is our maternal data center. And so what the maternal data center is every hospital, all 209 of them in the state of California, is part of the maternal data center. And so they send all of their discharge diagnoses for mom and baby into the maternal data center. Then there's supplemental files of the quality nurses are reviewing, and then it's matched with birth certificate and death certificate data from Department of Public Health. And so it comes together, and then I think about it as like the magical computer in the sky mixes up all the data and then brings it back to member hospitals, and you have interactive analytics that help put QI practices together. And then we bring hospitals together in groups to work on, let's say, C-section rates or hypertension or sepsis. And now we're doing it with working on equity issues. And this is just an idea of what it looks like. We have run charts, so you can look and see, okay, what's my C-section rate, let's say, over time. And then we can think about what's been going on in our hospital at that time. You can also stratify by payer, stratify by race, ethnicity. And so these are really powerful tools for hospital leaders to be able to target interventions. So one way to approach equity is thinking about putting it in and weaving it into all of the projects that you're doing. So for example, we have where Stanford is a maternal health center of excellence for the country, and our big project is preventing inequities in hemorrhage-related severe maternal morbidity. And part of that work is around preventing anemia. And so we know anemia disproportionately impacts Black birthing people. And so we are weaving in that work into PRISM. We're doing a similar thing for our community birth partnership, which is where we are looking at integration of midwives and home birth transfers. We're doing the same thing with preeclampsia, our low-dose aspirin for prevention of preeclampsia and preterm birth initiative. Again, we know that that disproportionately impacts Black birthing people. And so when we're thinking about these interventions, we are choosing carefully and then making sure that we're considering the equity issues in all the projects that we're doing. We do the same thing for our sepsis work. I'm looking at the time, I need to go faster. We need to do the same thing for our sepsis work, our redesign of the postpartum. And then as we are reviewing mortality cases, one of the things, and I'm super proud of it, it was actually just published in the Green Journal, is our hemorrhage review. We look at evidence of bias. And so inside of that article, we discuss how do you look for bias in a medical record? Like, what are the types of clues? Because nobody is going to say like, oh, I'm being a bigot today, I'm not going to take care of this lady. Like, that doesn't happen. So what are the clues? What are the clues around delay or dismissing? Like, husband used loud voice and ushered to waiting room. Like, what are the clues that patients aren't getting the attention they deserve? So that is one of the ways you can actually take equity as a concept and weave it into the work that you're doing based on the data that you have. And now, for the first time, and this started in late 2022, we have for the first time an actual collaborative that is very specifically focused on equity. So instead of saying, I'm focusing on anemia or I'm focusing on sepsis and I'm weaving equity into it, it's I'm focusing on equity and then I will look at clinical outcomes. So it's a little bit of like turning that model on its head. And I would offer that both are totally reasonable and you're going to get the best outcomes when you are doing both approaches. And so we started with a pilot, like everything we do at CMQCC. And California has I don't know if they have it in Vermont or not, but has mandatory implicit bias training for all hospitals and all personnel that take care of birthing patients. And so these were our first 5 pilot hospitals. And in our pilot, we pulled out sort of what are some of the key things that we need to do to move the needle. We need to think about accountability. We need to teach providers how to do better active listening. We have to teach providers how to really use their data to drive change. We need to shift unit culture. and then create a guide or toolkit for hospitals in partnership with community to figure out how to move the needle. And this hospital action guide for respectful, equity-centered care is, I can say, one of the projects that I've worked on in my career, of which I am the most proud. And then we have to assess it. We have to assess the efficacy and then spread the interventions. And so now, inside of CMQCC, we have 3 different equity-centered projects. So one is our CDC-funded learning initiative to support vaginal birth through an equity lens, and we use that guide that we designed as the curriculum. This is an 18-month collaborative. So this is not a 2-hour checky box or a lecture. This is an 18-month collaborative to figure out, how do I create equitable environment on my labor and delivery and postpartum unit. And the measure that we look at is disparities in C-section rates. We also look at the culture of equity survey. We also look at patient care experience, but that is the C-section rate is the main, and it's not just the overall C-section rate, it's disparity between your largest group and your outlier group. So it might be Asian patients, Spanish language patients. It's bridging that gap, which is the goal. And then in PRISM, that is again in an NIH-funded project where we're looking at inequities and hemorrhage. And then the culture of equity survey, where it's actually a survey looking at how people treat each other on the unit. So not how you're treating patients, because if you're having a culture of equity, you've got to teach each other how to be respectful of your colleagues. And then you can use those same tools to treat your patients with respect. So if you go onto cmqcc.org, that's our homepage, and you can see all of our equity initiatives there on the page. I spoke of our hospital action guide for respectful and equity-centered obstetric care. We were going to launch this month, given the current political climate. It's launched for California, and all the hospitals in California can use it, but we're sort of reassessing before we launch for the rest of the country, but definitely stay tuned. And these are the modules. So this is the curriculum for the learning initiative. This is available to all the hospitals. Every hospital in California can get its stratified data from us in order to put this programming together, so that we can start with knowledge, figure out how to use data, look at your practices on your unit, think about how you are learning from your patients, creating a culture of respectful care, and then going into the community. And we went back and forth a lot about, do you put community in the beginning or towards the end? But we want people to sort of clean up their own house first, and then start reaching out into community, but while having community advisors the entire time. So when you're thinking about putting together an accountable and sustainable equity model, we have to really make sure that when we have community partners engaged, that we are centering their lived experience, we are compensating them for their expertise, we are having two-way communication, so that when we have findings, we're going back into community in order to make sure that they know what we're doing. Now, I spoke of the collaboratives. We're on our third round now. We've had about 30-ish hospitals, but we've had even more hospitals going through our webinars. So our webinars are open to the public. And so we've got lots of engagement going on, and we're actually moving the needle, which is super exciting. We support any California hospital that wants to work on equity issues with office hours, and we're really giving them the tools to figure out how to do community engagement. Because PS, pregnant and postpartum people don't spend their life in the hospital, or even in the doctor's office or clinic. They're actually out in community. And we can see from the shifting trends of maternal morbidity and mortality that more and more complications are happening in that outpatient space. So we want to really make sure that we're helping hospitals figure out how to foster collaborative relationships, um, and really be able to give more respectful care. So joining networks or collaboratives that bring people together to work with community, thinking about engaging social services, public health. We help our hospitals figure that out. We get them engaged in things like Black Maternal Health Week, where we are right now. So most of our hospitals that are in our collaborative are having events. They're lifting it up on their social media channels. They're having discussions. So these are the sorts of things that we do to help our hospitals figure out how to work with community. And so it might be advisory council, it might be town halls, it might be having a community breakfast. There's so many different ways that we can engage community in a meaningful way, but we've got to be careful of the pitfalls. Oftentimes there'll be issues around budget, resources, like do not try to do this on a shoestring, because it will then end up being kind of disingenuous and not as impactful. You've got to use trusted messengers. Think about your community health workers, doulas, that might be able to bridge. And then we got to make sure we're evaluating it. So these are some of the pitfalls that organizations can run into. And these are my colleagues, Drs. Lindsay Duplessis and Joanna Tillman, out in community. And we're doing it to try to help our hospitals really be able to be connected to where their patients are coming from. And then lastly, I'll just say a few words about patient stories. As we're doing community engagement, we have to be mindful. Do patients see themselves reflected in the work that you're doing? And so on our CMQCC website and on the March of Dimes website, you will see videos and stories about the patient care experience, because so often, and I can tell you, taking care of thousands of patients, something even as simple as common, I should say, as a C-section, you know, between a quarter and a third of patients might be having a C-section, yet I cannot tell you the number of times people say, well, I didn't think it would be me. And you're like, come on, dude. Like, it's a quarter of patients. Of course, there's a big chance that it's going to be you, but that is not how it works in so many patient brains. And so we've got to be able to tell stories so that patients know what is possible, what they should be on the lookout for. We don't have time to show this video today, but Allison Felix has been a huge advocate, both in the CDC Hear Her campaign and also in our March of Dimes campaign for preeclampsia and using low-dose aspirin. Because she's an Olympian, for crying out loud. Tori Bowie was an Olympian. Like, things happen to people who are really healthy. Is still possible. So being able to get the story out to patient is an important part of moving this work forward. So, in summary, if you are designing and thinking about equity for your unit or your institution or your health plan or your hospital, these are some of the key steps when you are thinking about not just making a checky box training, but actually designing for sustainable change. You've got to get your key stakeholders aligned around the problem that you're trying to solve and pick the right language for it. You need to build a framework for advancing health equity. You've got to train people on how to use data. You have to think about designing projects that either have health equity woven into them or that prioritize equity in their design. You got to get community involved. partially to keep you accountable as an organization and to think about your pregnant and postpartum patients across their lifespan. And then I would really encourage you to prioritize patient stories so that so all of us who are doing the work can prioritize that this is real people's lives and that all of this data actually has impact, and so that patients and community can be engaged in the work that you're doing. All right. Hopefully this has been helpful to you guys. I really appreciate your attention to it and willingness on this Black Maternal Health Week to think about how you can at UVM start making some changes. And I know that so much good work is happening already.
Thank you so much, Dr. Williams. I think I speak for everyone who is attending this session. What an impressive body of work that you and your team have been able to build, and how thoughtful and truly equity focused all of these initiatives really are. And I think you and your team are certainly a model of how to do this work and how to do this work in the best way possible. So thank you so much for example and for all of this incredible time and effort that you've put into such truly remarkable steps that you're taking there in California, and that will certainly, hopefully, impact us all across the US and really worldwide, likely. So thank you so much for that. Right now, we'd like to take the last few minutes that we have and open this up for questions. So please, audience members, please feel free to place your questions in the Q&A box, and we will happily address those. Tiffany, I do not see any in there yet. I am happy to ask a few if that's okay, Dr. Williams. I'm fascinated with so many different areas of this, and I think we as a network and we as the College of Medicine often talk about how to think about using our data, particularly health equity data, in a responsible way. So looking at the model of the maternal data center, I'm fascinated with that. Would love to, I'll probably reach out to you separately and sort of do a deeper dive in that. But when you're collating that data, what equity metrics are you evaluating, and what are you using to show impact? Because that's one of the things outside of mortality that we're often talking about is how do we really show impact with this work, because we know it's working, but what are those opportunities that we can really show that in the data? If you wouldn't mind to speak to that.
Yeah, please. I'm a data nerd. So this is my jam, is data stratification. So first you have to have the capacity to stratify your data. And there's so many different things you can stratify on. You can do rural versus urban, commercial insurance versus Medicaid. You can do primary English language, racial groups. So first is the intentional design for the capacity to stratify data. Inside our maternal data system, we have 126, I think, right, as of last count, quality metrics that are inside of the maternal data center. So of course, things like C-section rates, exclusive breastfeeding rates, hospital readmissions, all of these different quality metrics. Of course, we have the, Joint Commission stuff, HEDIS stuff, but also the different pieces of that sort of pregnancy postpartum journey. I would say I always like to prioritize, and this is it's not that the other things don't matter, the other quality metrics don't matter, but the ones that are the most direct drivers of mortality is usually where I would recommend starting, because it's the easiest way to get that engagement. So SMM, severe maternal morbidity, is a big one. C-sections are another big one. So those usually are the places where I would recommend starting if you're trying to get stakeholder engagement and show that you're driving towards this outcome. There are also a well-established disparities. And so every hospital, let every hospital, and they own their own data. So it's very tricky in terms of data sharing agreements. We've got lots of lawyers that we work with. But because we always want to protect the confidentiality of our patients. But starting with stratification of those areas on a clinical outcomes side is important. We also give, when they're in our collaborative, we help our hospitals figure out how are you capturing patient care experience, because that's data also. And we can't forget that patients' experience and uh, oh my gosh, why am I having word finding difficulty? HCAHPS. Our HCAHPS scores are not going to give us the full story. So what are the other survey tools or town halls or listening groups that we can use to get patient feedback is really important. And then this culture of equity survey allows you to see what's going on your unit. So finding measurable outcomes that are not a like once in 10 years type outcome to help show the impact of your interventions is key.
That's incredible. And Tiffany, throw to you.
There's actually a couple of questions in the Q&A. So the first one is, can you talk about why the SMM has been increasing? What are the underlying factors? You mentioned more factors in the community setting.
So sorry that's maybe I wasn't clear. So SMM is very hospital specific. So SMM includes things like eclamptic seizures, ICU admissions, OR takebacks, massive hemorrhages, sepsis on pressors, like that sort of thing. So that is what SMM is. SMM has been increasing over time. That is definitely true. And some of that is around sicker patients, older patients, patients coming into pregnancy less healthy with diabetes, hypertension, et cetera. So from a longitudinal standpoint, that's why SMM uh, probably is getting worse, and that we're not doing a good enough job of managing those conditions prior to and in early pregnancy. In terms of the racialized differences, those SMM differences aren't really well understood, but the sort of leading theory is it's about response time. It's about listening and response time. That it's a combination of patients not being heard, that they're having a complaint that, oh, I have this weird feeling in my chest, or I'm feeling a little headachy. And the doctors and nurses not hearing them in the same way. And then also patients feeling like, okay, well, I've been disrespected. Like, why should I even call my doctor and tell them that I have a headache? Like, what's the point? Why even ring the call light? And then delayed responses. So delayed responses when patients do give the complaint. I often use the line, the more different someone is from you, the harder you need to listen. So we are just animals with this like very primitive limbic system. And if you've got a trigger that says, oh, that's my sister, that's my cousin, like you are going to respond differently. But if someone's really different from you, you don't have those shortcuts. And so we've got to use our cognitive skills. We've got to use the top of our brain to say, like, slow down, pay attention, listen deeply when someone is speaking to you.
Thank you. And actually, there's one more question. The member says, something that interests me about this topic that's maybe not as quantifiable is generational trauma that gets passed down through people of color and their aversion toward healthcare. When you're encouraging clinicians toward equity over equality, is there any conversation around this topic? And what role does this trauma have in your efforts to create better experiences for patients?
What a juicy question.
Yeah.
Yes. We need to speak into it. And part of what I do with some non-Indigenous, non-Black allies is encourage them to say the words, like say that you are recognizing that there is a generational issue here, that there may be distrust, that you know the history of how Black bodies have been treated in America, and that you are actively working to not just be different, but acknowledge that that exists. I mean, there is deep, well-earned distrust in many communities. And so if we're going to turn that on its head, we have to acknowledge that it's the case. We need to reach out and engage our trusted partners, like community health workers or doulas that might be working in a particular community, that could be bridge builders. We have to acknowledge that that exists, and also call out what's going on in our epigenetics, and that in that methylation, the oxidative damage, the chronic stress, all of that cortisol in your body, these things do have downstream consequences in terms of one's physical health. So it's not something you're making up in your head that like, oh, she's just taking in something too seriously, or these sorts of dismissive attitudes. This is really happening in people's bodies, and acknowledging that sort of generational trauma can be part of a beginning of a healing process.
Well, Dr. Williams, thank you so much. I think that finishes us up here at 1. We just want to thank you again for such an incredible talk on a really important topic. And again, just want to thank you for engaging with us and our audience members, and to all of our audience members for attending our healthcare series grand rounds. As a reminder, if you plan to claim CMIE credit for this event, please use the links in the chat. We hope you can join us for our next event, which is a collaboration between the Teaching Academy and the Office of Inclusive Excellence, featuring Dr. Lisa Meeks, and that is on Friday, May the 2nd at noon. We hope to see you then, and we hope you have a wonderful afternoon. Thank you again, Dr. Williams. We really appreciate it.
Thank you so much for having me. You guys have a great rest of your day.